up to the seniority wise you are asking?
Beta, it's not seniority. Rather, you will say that it's according to the condition of the patient's prioritization given to the patient according to risk to the patient
Factors
and to the pregnancy. ठीक है? So
okay,
in
we
this
have
way,
to prioritize the patient as it is low risk, high risk, and then we have to refer the patient towards that level doctor.
yes, yes, exactly.
Okay, ma'am.
So actually, generally, what happens that whenever you come across a station that you have to triage the patients in the labor room, then how will you do this thing? So usually, definitely, your first priority is a high risk pregnancy, or a high risk patient. So who is a high risk patient? Who is actually hemodynamically unstable. So all of you know that what is hemodynamically instability. What is hemodynamic instability? Either she is in a state of shock, or just few seconds, and you have to decide the mode of delivery or the plan. You have to take plan immediately, or you have to take plan at some senior level. For example, you have to involve some senior registrar in case of placenta previa major degree who is bleeding and she presents to you, or if there's some patient with placental abruption and she is also showing that signs of concealed as well as revealed hemorrhage, and she is in a hemodynamically unstable, or a patient who is in a state of cardiovascular or septic shock. So definitely you have to prioritize this patient as top category, and then later on, according to that, to the patient of the presenting complaints of the patient, definitely you have to divide the patients. For example, if a patient who is who is in labor, and she is dilated to about 6 centimeters, and her labor is going in a way that CTG is normal, and the rate of cervical dilatation is 1 centimeters per hour, fetal heart rate is okay, and if you do the controlled ARM, you see that liquor is clear, then do you think it is a high risk pregnancy?
No, ma'am.
Not in a sense, because she is hemodynamically stable, and she is the cervix is dilated according to the normal parameter. Fetal heart rates are okay. The liquor color is also normal. So in this way, just you have to watch the patient and maintain the labor care guide and deliver the patient accordingly, and be vigilant for the postpartum hemorrhage. Now the second scenario is that a patient has come to you. She has previously three lower segment C sections, and now she comes to you with painless bleeding per vaginum, and she is having a weak and thready pulse and decreased urine output, and there is tachycardia, and also there is sweating. So
She's hypovolemic shock, so
yes,
it's high risk pregnancy.
yes,
so
then
we have to alert the senior obstetrician.
definitely you have to not only alert the senior obstetrician, but you have to call the senior obstetrician. In this
And
case,
anesthetic team,
uh-huh,
proper team.
exactly, you have to localize the placenta, rule out the morbidity adherent, so that the need of hysterectomy, and in case of hysterectomy, she is in need of at least 6 units of blood after blood grouping and cross matching and consent, and all these are to be done. So definitely you have to inform the senior registrar, and ultimately a senior will be washed up in this case. Okay. Now another patient is presented to you, and you find out that she has been delivered, and there is some her episiotomy has been stitched, but you find some bulge in the episiotomy stitch. So you feel some hematoma there, and it's increasing in size. Then do you think it's a high risk or some low risk pregnancy?
Ma'am, we have to be drain the hematoma by incision and drainage local anesthesia if it's needed. Or
Yes.
if she is discomfort with local, then we have to give a journal also.
Yes, so definitely it
So
means that
properly.
some bleeder has been there, which is not properly ligated, and ultimately you have to oversee this area, or you should drain the hematoma and stitch that area so that no active bleeding is there. So you have to be vigilant for this. You cannot leave this patient as such, or you should say that you cannot hand over this patient to some house officer. ठीक है? Some
Yes, ma'am.
expertise are required in this case. Now another case is presented to you, and she is progressing normally, but once you do the controlled ARM, you find it is meconium strained liquor. Now, do you think it's a low risk or high risk?
It's high risk pregnancy because fetal distress is there.
Yes, you cannot say that there is fetal distress. You don't know that. You have to definitely you have to do the continuous fetal electronic fetal monitoring, and you have to see for the progress of labor, and you have to be vigilant for the risk of meconium aspiration. You have to counsel, and you have to if she is progressing well and near to delivery, definitely you will deliver. But if os is not properly dilated, then definitely you have to plan emergency lower segment C-section, and you have to involve some senior in this case. And furthermore, if you find a patient who is having who is previously grand multiparous, delivered at home, now bleeding profusely, and she is having sweating and cold clammy skin, then do you think it's a low risk or high risk pregnancy?
Can you repeat, ma'am? Cold clammy skin.
If a patient who is grand multiparous presents to
Okay.
you and she is bleeding after delivery at home, now she is
Okay.
having bleeding, profuse bleeding, and
Yeah, it's a high risk. It's high risk because
yes.
she has gone in PPH and she has history of
Hmm.
home delivery. Might be there is DIC or PPH or a Tony. So
Yes.
we have to look for the proper care, and we have to shift. We have to explore first if the clots are removed, and we have to exclude the cause of atony. If the cause of atony is not going to be, we
But
have to see
you
the
are
clotting
very right,
profile.
beta. But Dr. Humera, first of all, you have to not you the care you are giving is very fine. But at the same time, you have to do ABC. That is airway,
Okay,
breathing,
ma'am.
circulation. You have to maintain in the meantime because you don't have time. If she profusely bleeds and you're
Yes,
just
ma'am.
focusing on the source of bleeding and you continue on massaging the uterus, or like you go for uterotonics, in the meantime she is bleeding, and her shock can be irreversible, and ultimately she
Okay, ma'am.
cannot be reverted back to the normal na. So that is why what you
Yes.
have to do is that you have to image, as we have studied the flow chart in Dewhurst, जिसमें आपने आपको कहा गया
Yes,
कि टू
ma'am.
वाइट बोर आईवी लाइंस पास करनी है, आपने इमीडिएटली आपने पेशेंट का एयरवेज, ब्रीदिंग, सर्कुलेशन सिक्योर करना है. द फ्लूइड which retains inside the circulation is actually either crystalloid or colloid. So you have to give either
Collision.
crystalloid or colloid immediately. Meanwhile, you have to arrange the blood, which is group specific, or you have to arrange O negative blood immediately, and you have to take blood for sampling, for cross matching, and for the rest of the tests. And in the meantime, side by side, it's a teamwork. You have to call for the team, and you have to go for first of all just bimanual massage of the uterus, because 90% of the cases there is uterine atony. So you have to rule out the factor behind. You have to see either it's atony, and once some contraction of the immediately start the syntocinon infusion, and once the bleeding is controlled to some extent, then definitely you have to explore that what is the cause behind. It can be tissue, it can be thrombin, or it can be what are
Trauma.
forties?
Torn tissue trauma thrombin.
Yes, stone, tissue, trauma, or thrombin. So, in out of four T's, you have to see what is the cause behind. So, according to the cause, you have to manage this case. And since already she is grand multiparous and she is profusely she is bleeding, so definitely you have to replace the blood. So, it's a high risk pregnancy. So, another patient comes to you in the labor room, and she has missed miscarriage at almost 16 weeks gestation. And you see, you confirm it that the fetal heart is not found and it's missed miscarriage. And on provisional examination, you find that os is closed, and previously she was having normal vaginal delivery. So do you think that she is a high risk pregnancy?
No, it's not high risk, ma'am.
Yes, it's not a high risk, so you can hand it over to some other than senior, and you can hand over to some doctor in such a way that definitely you have to go through the workup of this missed miscarriage. You have to go for the coagulation profile of the patient, and you have to see for the hemoglobin value in this case, and definitely consent of termination of pregnancy, and discuss with the patient either you she wants expectant or she wants medical or she wants surgical. All these options are to be discussed, and then you will plan after cervical ripening in this case. Okay. So this patient is basically a planned case in which you have to plan after getting the investigations done. It's not a high risk pregnancy. Okay. Now, another patient comes to you, and you find it out that she is having, once you go for the CTG, and you find out that it is showing variable decelerations, and you assess the CTG for about 20 minutes. So, what's your plan in this case?
What's the
On
age of gestation?
Yes, it's about she is at term, and she is priming gravida, and on provisional examination you find that os is not open, and she is for 20 minutes CTG, she was complaining of reduced fetal movements, and for 20 minutes CTG you find out that there is variable deceleration. So how will you proceed in this case?
Ma'am, we have to do the gold standard. The ultrasound is the best in case of reduced fetal movement, but we have to monitor continuous electronic fetal monitoring, and we have to maintain the posture, left lateral position, and IV hydration.
And in which case variable decelerations are found?
In case of ma'am, fetal distress, and also it's also high risk because there is variable deceleration, cord compression, ma'am.
Yes, it is basically the cord compression. So why can be the cord
Okay.
compressed? How can the cord be compressed?
Because of the head pressure, ma'am.
It can be due to some kinking of the cord. There can be it can be in
Descent of presenting cord.
yes, descent, or it can be trapped around the head and there is compression. So in this way there can be compression of the cord. So you know that because
Fetal hypoxia.
yes, the cord is the source through which the blood oxygen is being supplied to the fetus. So once it's compressed, definitely it leads to hypoxia to the fetus. So if your CTG is showing that there are variable decelerations and continuously by assessing it, it's not relieved. So ultimately she is at term, she is not having good bishop. So definitely because of this although the guidelines they say that in that case you have to do the electronic fetal monitoring, and you also if feasible for you, you have to see at least two factors, and also if fetal hypoxia, then fetal scalp blood should be taken, and pH should be seen, and hypoxia assessment should be there. But in this case, definitely keeping in mind, if you do not have expertise, you have to arrange emergency lower segment C-section if continuously you assess the variable decelerations, and also she is having reduced fetal movements, and fetal distress suspicion is in this seen in this case. Okay.
Okay, ma'am.
Okay, now another case, for example, a patient presents to you, and she is having previous one C-section, and now she is having a breech pregnancy, and now she is early labor. So how will you proceed in this case? She is at term.
We have to follow the breech delivery protocol, ma'am. But what is the bishop score? And
As I've told you previously, that she is in early labor. So
she's in early labor.
so
Okay.
definitely you have to plan C-section, because A plus B is equal to C. One risk factor is C-section in the previous
Yes, ma'am.
pregnancy. Then
Previously.
second size risk is she is having breech. She is in early labor. You don't know how will it
Yes,
be
ma'am.
proceeded, and also you are afraid that there can be a entrapment of the after coming head. So definitely in this case, in early labor, you have to plan emergency lower segment C-section.
Okay, ma'am.
ठीक है, इसमें फॉर्मूला आप याद रखें कि A plus B is equal to C, यानी कि 2 रिस्क फैक्टर्स आ गए हैं तो C-section should be there.
A plus B is equal to C. A is for previously
मतलब
sected patient,
A
previous
is
history
one,
of C-section.
yes, A is one risk factor, that is C-section. B is another risk factor, that is breech, and then this
C
ultimately
is early
results in
labor.
C-section. ठीक है, तो ये इसका risk factors they will end up in the C-section. ठीक है.
Okay.
So just today I wanted to discuss few scenarios relating to triaging of the patients in labor room, so that how you triage, and always remember that if a patient who is hemodynamically unstable, always that patient has to be kept at top, because ABCs are to be maintained, that is airways, breathing and circulation have to be maintained immediately. Then rest of the things are definitely taken side by side, and always it is a teamwork. You have to be with the team to manage the patient. Okay. And one important thing is that in case of either it's abruption and she is not stable hemodynamically, you should keep in mind that she might be bleeding, having internal bleeding, that is concealed hemorrhage, not revealed but concealed. So once there is excessive bleeding, then ultimately what will happen, she is at risk of disseminated
Shock,
intravascular
hypovolemic
coagulation.
shock.
Hypovolemic shock is also a risk. DIC is also a risk. So lot of risks are there in these cases, na. So you have to immediately plan for these cases. Similarly, a patient, for example, she is unconscious, presents to you again, she is in shock. So you have to see for the cause, and many a times what happens that there is what happens that because of gravid uterus there is pressure on what else? Aortic cable.
Inferior vena cava.
Yes, aortic cable compression is
Inferior
there.
vena cava.
Yes, there is the gravid uterus exerts pressure on the major supplies, and ultimately there is aortic cable compression because of lying straight. So immediately you have to tilt the patient to left lateral, and then you see that if it's improved, then definitely you will monitor, and if it's not improved, then definitely you have to do other strategies in this case. Okay.
Yes, ma'am.
And always you know that in case of mother and fetus, who is at top?
Mom.
Who is to be saved first?
Mom.
Yes, mother is to be saved first. So always,
Mother is on top.
yes, mother is to be saved first. You have to assess for the hemodynamic. We just take the vitals of the patient very lightly. However, vitals are very much are of very much significance, because they tell you that either she is hemodynamically stable or unstable, and according to that you have to plan the case. Okay.
Yes, ma'am.
Okay. Any question?
Ma'am, if the patient is unconscious or conscious and hemodynamically unstable, we have to first go for ABC.
Yes, it's a teamwork.
Okay.
Okay. Always
Okay.
remember that for high risk pregnancies, immediately call for help. And after calling for
Okay.
help, you have to immediately side by side you will do the things, like you secure the airway, you establish the breathing, You pass two wide bore IV lines and ensure that adequate circulation is achieved. Always use the isotonic fluids, either crystalloid or colloid, which stay in the circulation, and so that the blood pressure is maintained in this case. And meanwhile, the other cause, if for example she is having APH or PPH, definitely of 4 T's, that is tissue, thrombin, tone, and trauma. So in out of 4 these, you have to see that what is the cause. So according to the cause, you have to manage, and everything accordingly. You will go very systematically, and you have to categorize these patients according to their presentation, and similarly according to the presentation of the patient, you have to hand over the patients to the your doctors. Either for example, if she is hemodynamically unstable and she needs immediate management, then definitely SR should be called at this case. And if just she needs a waitful watch, or she is in wait of investigations, or she is in wait of some planned procedure or elective procedure, then just you can hand over to some first year resident or house officer. So basically it's a triaging of the patient, and generally in labor room there is a triage room where we categorize the patients and distribute them according to their presentation.
Okay, ma'am.
Clear?
Yes, ma'am.
Okay. Should we end the class now?
As you wish.
Okay, but thank you. Allah Hafiz.
Okay, bye. Take
Allah
care.
Hafiz. Thank you. Same to you. Allah Hafiz.